Welcome to Clinical Conversations, a Journal Watch podcast for the week ending April 3rd. This is podcast number 81. I'm Joe Elia. For links to earlier offerings, go to podcasts.jwatch.org. For a more detailed look at the world of clinical medicine, go to the mothership. Just aim your browser at jwatch.org. Our conversation this week is with Richard Kahn. We talk about his paper published online in the Lancet earlier this week, which explores the question of when best to start screening for type 2 diabetes. We start with a summary of the week's most important clinical news stories. The Centers for Disease Control had some 2009 H1N1 news this week that's not very comforting. It seems that the virus, which many of us had considered lost in the mists of medical history, has made a comeback. Georgia, of all places, the home of the CDC, reports a continuing upsurge in hospitalizations. The other influenza news is also of small comfort. It seems that only about a third of healthcare workers had received their H1N1 shot as of mid-January, according to a CDC survey. Not good if we're going to see more admissions from this virus. The vaccine supply is plentiful, so go get some. Next, in happier news, a London acute care hospital group reports in the Lancet that it was able to reduce its relative mortality rates by almost 20% in a year's time through the use of checklists. The group drew up 8 evidence-based checklists, which they call care bundles, on topics like central line infection, MRSA, and heart failure. The bundles were made widely available to the hospital's clinicians. Within a month, mortality rates began to fall, and after a year, relative mortality, on a scale with 100 being the national average, fell from 90 to 71. Pretty good. Next, we have a New England Journal of Medicine study of whether dutasteride, a drug used in benign prostatic hypertrophy, would work in preventing prostate cancer in high-risk men. It apparently lowers cancer incidence, but not the incidence of high-grade tumors. An editorialist says that the 5-alpha reductase inhibitors like dutasteride merely shrink low-grade tumors temporarily rather than preventing cancer. And because the drugs suppress PSA levels, they may provide a false sense of security. And lastly this week, rosuvastatin's new indication for use among older people with a single risk factor drew some scrutiny in the New York Times. A front-page story wonders at the cost-effectiveness of a treatment that would have to be administered to 500 such patients for a year to prevent a single heart attack. At $3.50 a pill, that amounts to $638,000. Not cheap. That's the news. Now here's this week's conversation. You're listening to Clinical Conversations. Lancet this week released online an analysis of the most cost-effective approach to screening for type 2 diabetes. The researchers used data from the U.S. National Health and Nutrition Examination Survey, NHANES, and modeled a population of some 325,000 subjects without diabetes at age 30. Then, using simulation software, they examined 8 sequential screening strategies looking for their effect on when diabetes would be discovered and the effects of treatment and the implications for morbidity and mortality. The sequential strategies ranged from starting at age 30 and repeating every 6 months, so-called maximum screening, to starting at age 60 with repeats every 3 years. The control was waiting for symptoms of diabetes to manifest themselves. We are fortunate to have the paper's first author, Dr. Richard Kahn, as our conversational partner today. Dr. Kahn is professor of medicine at the University of North Carolina. Welcome, Dr. Kahn.
Thank you very much. Thank you.
Your design, we should remind our listeners, was based on simulation using data from real people. And your paper mentions use of the Archimedes model. Since it's the basis of your findings, can you briefly describe the Archimedes model?
Sure. This is a model that's a virtual simulation of a healthcare system, and therefore It has virtual people going to doctors, virtual doctors getting virtual tests and procedures, getting virtual drugs, having virtual events like heart attacks and blindness and amputations, going into virtual hospitals, and all the time running up virtual costs. So it really is like the game SimCity, if anyone's familiar with that, in which it basically tries to capture the real world in a virtual world. It's a very unique model in that sense, because the existing mathematical models used in medicine are either an equation. The most familiar one would be the Framingham equation, which is, let's say, 6 variables, and it predicts heart attacks at 10 years, not 8 years, not 12 years, not in people who've already had a heart attack, not in people who are on drugs. So they're either so-called regression equations, or they're models that actually simplify things very greatly. They say, let's say, health, heart attack, or death, and you're in one of those states and you progress to another state. This model is very different. It works on scores of, I call it ordinary and differential equations. They're all integrated, and it really runs on basically underlying physiology. So it's not just a person, not just a virtual person, but they have virtual physiologies. They're making insulin in response to glucose. They're forming plaque as they go along in their daily lives. Some have no effect of all this. Some have a severe effect after a couple of years. And the last thing I'd add about the model is that it is extremely well validated, very different than any other model, who doesn't really come close to being validated. In that validation means that the model is able to replicate a clinical trial in the virtual world. So you take people and randomize them like they did in a clinical trial. You apply the procedures, you follow them, and then you see if the results of the model match the results of the clinical trial. So they never use the results of the clinical trial to develop the model whatsoever. They want to see if will the model replicate the clinical trials. And I think they've done well over 50 clinical trials, which means well over 100 arms, since each trial has at least 2 arms. I think it's like 140, 150 arms. And the model's only been off like 2 or 3 times. So it's impressively accurate in simulating the real world.
You mentioned that it's very computer intensive, and so you used, you say in the paper, distributed computing. What sort of computing power are we talking about here?
Well, what distributed computing allows you to do, and actually distributed computing is claim to fame really is in the search for extraterrestrial people,
right? And
where thousands of individual home computers are being utilized. So basically, we're talking about 500, the equivalent of, let's say, 500 to 1,000 computers running on a particular problem for maybe 10, 15 minutes. To give you some perspective, what that means is if you took an Excel spreadsheet and you filled every single row and every single column with whatever number you wanted, 10-digit or 20-digit number, every row, every column, there'd be thousands of cells of all filled, and then you pressed enter, you'd get an answer back in about a second.
I see.
And so we're talking about 500 to 1,000 computers working over 10 to 15 minutes to get an answer.
And each of those 325,000 people underwent, in a virtual sense, each of these screening strategies. Is that right?
Right. They were taken and they were given each of these screening strategies, and then they're followed, and the computer captures virtually everything about their health care in every which way as they move along. And, as I said, some people would have a heart attack after 6 months, and some people would never have a heart attack and run up large costs and small costs. So it's pretty complex when you think of all these people. Now, in addition to not just following them in the sense of sort of watching them go about their daily lives, the computer is also simulating their physiology. So their blood pressure is going up and down, and their plaque formation is occurring, their kidneys are functioning, glucose is taken in, and so you're actually simulating their physiology as well. It's not just sort of watching 325,000 people from 1,000 feet above them and seeing what happens to them. The computer has to simulate all their physiology and all the pathologies to get the events, which is why it's so impressively intensive.
And those simulations are based on data from other real-world sources. Is that right?
Yes, the actual what forms the basis but someone's physiology or pathology or events or so forth, and that comes from looking at other trials and studies and making equations from those things. So there might be a relationship between race and the development of diabetes, or duration of diabetes and complications. And so what the Archimedes group did was to develop equations that represent that, and then test to see whether they actually made the equation correct. So in other words, they put in a number, and does it come out like the paper said it would? And then the next thing is to integrate those equations with all the other equations, and then see if you can replicate a clinical trial. So quite honestly, even though I have actually no interest, financial interest whatsoever in any regard, past, present, or future in Archimedes, it is a tour de force of a mathematical model.
Well, let's look briefly then at what Archimedes presented. Let's look at the advantages and disadvantages of some of the screening models that you used. For instance, the maximum screening model, which is the one in which you start at age 30 and then you screen every 6 months for diabetes. That adds the most quality-adjusted life years to the group, but the costs, which are roughly $40,000, are significantly higher than the other strategies.
Yeah, it's actually that's actually $40,000, not just simply $40,000, but it's $40,000 to gain one quality-adjusted life year, which is 1 year of sort of perfect health, and that's a pretty hefty price to pay to get that kind of quality-adjusted life year when for, let's say, 45 years of age every 3 years, as opposed to screening every 6 months, the number of quality-adjusted life, the quality-adjusted life years goes down considerably, I think, from like about 200 to 115 or so, or 130. But the price drops dramatically from 40 some odd thousand to like 9,500. And if you couple that with lipid screening, so screening starting at age 45 every 5 years, which is the same as the recommendation for cholesterol screening for age 45 every 5 years. Then we're talking relative to the maximum screening of a quality-adjusted life year going from 40,000 to about 6,500. So like 1/10 that, whereas the difference in quality-adjusted life years that you accrue is actually maybe a 40% drop. So you get to go from maximum screening to screening 45 years every 5 years, you get maybe 40% less quality-adjusted life years at 1/10 the cost.
Starting before middle age approach seems to be the best, according to your interpretation of the data. Is that right?
Right, because I think that you really do want a benefit that is cost effective. Because as you know, and your listeners know, that costs of medicine, cost of healthcare is a very, very important factor, and so you want to get as efficient and effective as possible. You just can't have everything for everybody all the time. So you need to find interventions, in this case screening for diabetes, that's actually cost effective, and the most cost effective one that we found was age 30, somewhere between age 30 and 45. You could start at 30, you could start at 45, and screen every 3 years or every 5 years.
Were there any surprises in the findings?
Well, two surprises. I think the biggest surprise was the fact that a number of strategies are equally effective. So we had 45 every 3, 45 every 5, 30 every 3, and they're all in the same ballpark. So it wasn't that one stood out. Second, I think, big surprise is that they were all very cost effective. Sometimes we find strategies interventions that are 30, 40, 50, 100,000 per quality adjusted life year, which is huge, whereas these were actually turned out to be very cost effective. And I think the third result that was quite surprising is that since we studied 3 strategies starting at age 45, every year, every 3 years, every 5 years. And so let's take the difference between every year versus every 5 years. There'll be some people who will develop diabetes right after the screening, yet they'd have to wait 5 years for the next one.
Yeah.
Or 4 years, 4.5 years for the next screening. And the question was, well, in that interim period, is that a real problem to have diabetes for 4 years, 3 years? And in this case, it actually was like a 2-year difference, it turns out, on the average. A 2-year difference between those the the most frequent versus the less frequent starting at age 45. Was there a difference in the outcomes? And the answer is no. So skipping a year or two when you have diabetes, or having diabetes for a year or two before it's diagnosed, in the early stages of the disease, not in the late stages, in the early stages, doesn't seem to have a negative effect.
The American Diabetes Association now recommends screening starting at age 45 with repeats every few years. Are your findings likely to change that recommendation?
Well, it turns out they're in the ballpark of what we found. I think they say 45 every 3 years,
Right.
Or starting earlier if you have symptoms or risk factors. And 45 every 3 is very similar to what we say, which is you can do it 45 every 3 to 5. So I'm not sure whether they'll change or not. It's been a recommendation of the American Diabetes Association for many years. People are used to it. They may change, they may not. It would seem to be a little bit more cost-effective if you did it every 5 years because you can couple it with lipid screening.
And now with type 2 diabetes becoming more prevalent in the U.S., these results or the adherence to current guidelines actually are likely to have a big impact on healthcare costs. How carefully followed are those guidelines?
Well, I don't think they are carefully followed as a whole for the whole population.
Mm-hmm.
And of course, there are organizations that promulgate different guidelines than the ADA. Some say don't screen at all until you get a complication. Don't screen unless you have hypertension. Don't screen or screen every year starting at age 30. And so,
we have another visitor.
Yeah, we do.
That's all right. Don't worry about it.
So, they have different guidelines. So I think that if we all could get on the same page, it would help a lot.
Mm.
And all had sort of consistent guidelines. But I get the sense from the data that's out there, albeit a little bit incomplete, that people are not getting screened routinely. They're not.
Do you think that clinicians should be doing anything different next week as a result of these findings, or do you think that the best thing they could do is just hew to those guidelines?
Well, I think that they could be, looking at this paper and saying that, I do need to set up a schedule of screening for my patients. Mm-hmm. And, whatever it be, starting at 30 every 3 or starting at 40 every 5 or something like that, mm-hmm. They just have that and put that kind of tickler, so to speak, into the chart or into the electronic medical record that reminds them.
Okay. Let me just say, Dr. Khan, I'd like to thank you for your time with us today.
My pleasure. I enjoyed it.
That's it for this week. You can reach Clinical Conversations at 1-617-440-4374. Earlier podcasts are available at podcasts.jwatch.org, where links for all news stories can also be found. Clinical Conversations executive producer is Ador Yano. I'm Joe Elia. Join us next time, and thanks for listening.